All right, so thanks everybody for joining. This is Carol from the STS. Quite a nice group today. Sorry if I didn't get to read your name, but it's great to see all of you as I scrolling through. Today's March 20th. This is the STS National Database Quality Improvement Series. Today we're just going to talk about frailty. We'll come back to our prolonged ventilation hopefully next month with the Harvest 1 results. So we can look at it nationally. And then we're going to roll into the blood product utilization for our next National Quality Improvement project. So on the call with me today from STS, we have Emily Conrad, Addie Dolan, Banu, Leanne, Melinda, Nikki, Paul, and Sydney. It's like my whole family is here from the STS. I know I said Melinda. And then we have a special surgeon leader with us, Dr. Moritz Weiler von Balmus. Dr. Weiler von Balmus has been leading this effort to begin collecting frailty data. So he's here to support us during this call and answer questions. All right. So just quick STS updates. Beta blocker is ongoing. If you are collecting it, please continue to collect it. We're just doing it for the rest of 2024. Please try to get your cases in that correspond to the harvest deadline. We won't be looking at the data in much detail until the end of the year, but we're tracking it to see if we have any missingness issues or anything like that. So we want to catch those issues ahead of time and kind of fix any problems at sites are having. So please let us know if you're having any issues, but thank you so much for submitting that data. And then frailty is what we're going to talk about today. So frailty go live, it's a soft go live, will be April 1st. And we're having our webinar. So frailty data collection with a soft start on April 1st. And then we have our monthly webinar and that's not right. It's not April 3rd. Is it April 3rd? Hold on. Let me double check.
Yeah,
it is. Okay.
it is April 3rd.
Woo, I'm like, man, those dates are close. So we'll have our frailty data collection soft start April 1st. Our monthly webinar will be on April 3rd. And Melinda, what are we going to talk about on April 3rd?
Prior CV interventions.
Yay.
Coding.
It's exciting. Melinda loves it when I call on her out of the blue, by the way, if you haven't noticed.
I was ready for it.
I know,
I was ready for it.
You're getting ready. You're getting it. Quality Improvement Series webinar on April 17th. That's likely going to be, hopefully we'll have the Harvest 1 data back by then. If not, we'll find something else important to talk about. Maybe we'll revisit frailty just to check in with everybody and see how it's going. Either way, we'll have something good on April 17th. May 1st, 2024 is the monthly webinar. And Harvest Close H2 is May 24th. May 28th is Harvest 2 opt-out. Quality Improvement Series May 15th. And then the reason I went out this far is just because I wanted to get to the January date. So January 1st, 2025 will be the mandatory date to collect frailty data. So we'll start with our soft launch on April 1st, and then it will become mandatory on January 1st. Just a quick shot of the Harvest Close dates for you all. Next Harvest Close date is May 24th. The data from Harvest 2 is on its way over from IQVIA to STS to begin the analytics. So that process is going to start hopefully later this week or on Monday. All right, frailty, the need to know. So let's go. These are just some really high level points that often come across in the Q&A box after I go through the slide, and then they'll say, well, what about this? And then I'll have to say, or you'll say, oh, I joined on late. And I'll have to show you this slide again. So this is the slide. Go live April 1st. Mandatory will be January 1st. The data collection form and training manual will be posted later this week or early next week. However, I just confirmed with Melinda it will be next week. So we'll have those posted next week. And I'll talk more about this, how this timeline came to be. Letter to sites will be sent out before April 1st. Chair rises are needed only for elective patients, so the questionnaire should be completed on everybody. Chair rises only for the elective patients. The red cap form will be available on April 1st. Vendors will receive the specs by April 1st. They are not required to participate, but those that are able to and willing to will build out the specifications so you can collect it right in your vendor. I do not have a list of vendors that will be doing this, but just FYI, some of the vendors will be building this into their software. No decision on the required completion threshold yet, but that will be coming in the future, likely coming in the future. And the questionnaire and time chair rises can be performed by a clinician, including a medical doctor, NP, PA, registered nurse, or anybody that is clinical, whom the surgeon appoints to perform the questionnaire and chair rises. So let's talk a little bit about the data collection form and training manual. This is not posted yet because we wanted to have this call with you all today. I will be going through the data collection form and training manual in detail. There might be some slight tweaks made to it, but I'm not anticipating anything substantial. Following this call, it's likely that we will hear from a couple folks who are joining, and they might have a suggestion or they might have a question, and it might help us with how we're wording things in the training manual, or might be something substantial where we're like, oh my gosh, yeah, we totally missed this and we'll need to update it on the data collection form. So to avoid version control issues with the various forms, like to hold off until we get your feedback to make sure it's looking good on this from this call. And then we'll finalize everything. Once I finalize everything, I want to include the link to the posting for the data collection form and the training manual in the letter that we'll send out to sites. So that all kind of is coordinated to timer on this call and then what comes out of this call. So we can get this done within the next 10 days or so. So more information will be sent out to you. I wanted to have this call first. We'll finalize the data collection form and training manual and hopefully get all the information out by the end of next week to sites. And I think I went through everything else. Okay. And there's already 7 questions. So I'm gonna go. Let me go through the questions real quick before we go over to the data collection forms, just so we have a clean slate. Vicky's saying what's done with the frailty data that will start on April 1st. We're still collecting it. So as sites start onboarding the onboarding process at their institution to collect this data, we want you to submit it to us. And we're still collecting it. No data will be wasted, and we'll still use that to look at the results that you all send in to us. So please submit it as soon as you can. How many facilities are participating in the beta blocker project? And Nikki, I know you're on the call, I think. Oh, Nikki left us. I'm not quite sure yet. Nikki was pulling some data for me, so we'll have a better idea. I should have a better idea on the next call, Amy. Unless, Paul, you know. No? Okay. Our email's coming from STS encrypted now. Yes, we are sending emails. Melinda is sending emails encrypted from the FAQ mailbox. Melinda, do you want to talk about that?
Yeah, if I ask you for something that potentially might have PHI on it, like an op node or cath node or something like that, not that you would intentionally send me identifiers, but sometimes it happens. So I will send you an encrypted email so that it's secure. So that's me sending those encrypted emails to you.
Thanks, Melinda. And it should be pretty easy to utilize. It's not I don't think you have to set up a separate account or anything like that. It just says that the email is encrypted. Is that right?
I think you have to click on the open, like it's a red, from what I can see, because I can't really see much on my end, except some people say, send it back to me and I can see the picture. It looks like you click on the red button there that says open the email or go to the email or something like that. If anybody else has any more detail, because you're actually opening them, let me know. If it's more complicated than I think it is.
Okay, Jackie, I'm gonna save your question for the end about cardiac rehab. Shauna, regarding the soft and mandatory go live dates, are you referring to all right. Are you referring to procedure dates or data? Data entry dates? Do we start entering the frailty data for cases performed on April 1st or previous cases that are entered on that date? Cases performed on April 1st, obviously probably not gonna have the frailty information collected since we're just posting the data collection form and training manual, hopefully by the end of next week. So I would start with OR dates of April 1st and forward. And depending when your site is up with the process, that's when you should, do that. For the mandatory date, it will be mandatory, date of OR, so surgery date of January 1st and forward. Will IQVIA be adding the frailty data elements to the data collection form on the case forms in the platform? No, not at this time, Elizabeth. If our site chooses to, okay. All right, I'm gonna go to the forms now, and then we'll come back to the questions. So, Melinda, do you want me to walk through these like we have done before? Do you want to walk through them?
I'll let you do it, unless you want me to do it.
I like doing it. This is one of our favorite things to do. I think when we have done this before, what has worked out really nice is when we do side by side. And then I think we could do this. Okay. Ready? You see that okay? How's that,
Yep.
Melinda? Okay. All right, so the on the left there is the training manual. On the right is the data collection form. Just finalized the updating on it today. We just had a few things to take care of. Paul Meehan is working on the data specifications. Those are just about final to be sent out to the vendors and software specs as well. And then we have a physician, a clinician worksheet that we have, and I'll show that after we get through this part, right? I think this is the part that's of the most interest. So the first section on the data collection form is just basic information, participant ID, record identifier, participant identifier, date of surgery, and we're going to talk about these more in detail as we go down. So the adult cardiac database, frailty supplement training manual. We give a little bit of information about when it's starting. And then I guess frailty data collection will become mandatory with OR dates of, so we'll just see, this is what I mean.
Yeah, I'd already taken a note to update that.
Okay, so there it is. So I'll update it right now as we're doing this. Okay. And then it just explains a little bit about what REDCap is, how it's compliant with HIPAA, FESMA, GDPR, and 21 CFR Part 11. We will link to the REDCap form right here when all of this is final. And then if an error is entered into the REDCap form, just re-enter the form. As long as your participant ID and record ID and patient identifier were correct, just re-enter the form. If either, and we'll provide more clarity, I think we could add a little bit more here in the training manual. If either of these, any of these three were incorrectly entered, you'll need to reach out to us. Still re-enter the form, but I think we want you to reach out to us to let us know, because we won't be able to identify these in the REDCap if they're entered wrong. It's very important when we get down to that next section about entering in these three fields, with the most meticulous accuracy you have within yourselves. So we make sure those are correct for linking to the, data that's collected through the regular, version 4.20. If you need help desk for any reason, we'll have the link here for help desk, and then we'll post the link to today's webinar. Underneath this information, this is the February 7th webinar where we talked about frailty last time, and then we'll post today's webinar. All right, general information. Data collection for frailty will be done on all patients that are entered into the adult cardiac database. The time frame for the assessment is 90 days before surgery. Melinda, do you want to add what that means and what to do if the patient's baseline status changes? I'll let you take that and then we'll scroll down.
Yeah, what that means is that you can complete this data in the outpatient setting, and it could be done in a pre-op visit or a pre-op testing appointment. And you can have up to 90 days if the patient is the same day elective patient coming in to have the information completed. However, if there is some life-altering event that occurs to this patient prior to surgery that affects the frailty assessment, then you would need to complete another assessment prior to the surgery.
Okay, thank you. For urgent, so Melinda covered these first points. For urgent, emergent, or emergent salvage cases, so this is the status that's coded on the version 4.20 data collection form. The frailty assessment questions can be completed post-op anytime prior to the patient's discharge. So that will be the list of questions. The intent is to capture the patient's baseline functional status, so that will need to be kept in mind, and we'll add it onto the clinician worksheet. Capture the patient's functional status prior to hospitalization, acute illness. The chair rise evaluation is only expected on elective patients, so it's not needed to be completed on urgent, emergent, or emergent salvage cases, only on the elective patients. For you're welcome. Hand clap, woot woot. For patients scheduled for elective surgery, again, please complete the chair rise section of the data collection form. For chair rise evaluation is not expected on urgent, emergent, or emergent salvage patients. So we had that in there twice because right before this call, we were figuring out the best wording for that. But Melinda's gonna fix it. Okay. So let's go through these fields. The participant ID, this is the unique number that is assigned to each database participant to the STS. This is going to be your 5-digit number. It's either going to start with a 1 or a 3. So that will be your participant ID number. If you don't know what your participant ID number, it should be on your vendor software somewhere. It's the number that we use to identify you on your billing with STS. It should be on your reports as your PID number. That number needs to go into the first field that we collect. Next field is record ID. Now this number is going to be generated, and maybe what we should do here, Melinda, is add in some screenshots of what this looks like, specifically from the direct data entry site on the IQVIA platform, and then maybe just an idea of what it might look like from a vendor or two to see how it looks. So this is a number that's generated by the software vendor. It's either going to be generated by IQVIA or by your third-party software vendor. It's going to start with a V, and it's a unique number assigned to the record for that patient. So each patient is going to have a patient ID, and then under that patient ID, if they have multiple surgeries, they're going to have a separate record ID for each of the surgeries. That record ID, it's arbitrary, it's unique. It's a way to de-identify that patient. So when you submit this in, you'll enter in the record ID and the patient ID, 2 separate numbers. They're both going to start with V, the letter V is in Victor, and you can just copy and paste them right from your vendor software. That's the safest way to do it to ensure the accuracy of these. If these are copied in wrong or provided incorrectly to STS, when they go to link the data with the rest of the warehouse data, we're gonna have issues, figuring out which of these forms goes with which of the cases that was entered in during the harvest, close harvest time. So make sure that you enter these incorrectly, copy and paste them if you need to. If you have any questions about these, Melinda and I, or somebody at IQVIA, will be able to explain this to you better. But please reach out to the STS help desk at the email up above in this training manual. If you have any questions on what those numbers look like, they're always going to start with a V, so don't forget that. Date, and you have to include that V in the number, so it should always be a V. Date of surgery is the same field as surgery date within the data collection form. You're just gonna fill that in here. So we talked about patient ID, record ID, date of surgery. It's 8 digits. It's going, we can take this out. It's going to be the month, date, and year, 2-digit month, 2-digit day, 4-digit year in that format. And I think there's also a calendar. Usually Nikki puts in a nice calendar like that for us, but either way, that will be the format that'll come over to us. And it needs to match what's on the data collection form that you entered in for this record ID and patient ID in the vendor software or the direct data entry form. Okay. Now let's get into the good stuff. So we have the frailty assessment. First 2 questions are looking at ADLs. The first question is, indicate which of the following activities the patient needs any help with from another person. Select all that apply. So you'll select all that apply. Dressing, undressing, taking the bath, eating, drinking, walking around, getting in or out of bed, or a patient does not need help with any of these. If,
I think it's important to remember to exclude activities that the patient never had to do before or always relied on someone else to do.
Yep, exactly. So any help, thanks Melinda. So any help means that the patient is not able to perform the task independently. When we're talking about indicate which of the following activities the patient needs any help with, it means that they are unable to dress themselves completely independent. They need somebody to assist them, no matter if it's even just helping with putting on socks or shoes. And then select all that apply. If the patient, the last section or the last question where it says, if the patient does not require help with any of the following, then code does not need help with any of these. And then exclude activities the patient never had to do before or had always had to rely on someone else to do. For example, the patient always required help with eating. We're not going to consider this something that's new to the patient or something that's, decreasingly bad related to the frailty status. This is something the patient always required needing help with. So it's not a change in their baseline function. So we're going to not consider that one coding. These are just activities the patient needs any help with, but we're excluding activities the patient never had to do before or has always relied on someone else to do. Anything to add there, Melinda?
Nope.
Next question is indicate which of the following activities the patient needs any help with from another person. And these are a different set. I think these are called functional ADLs, right? Is that right? So using the telephone, going shopping for groceries or clothes, preparing their own meals, doing housework, taking their own medication, handling their own money, or a patient does not need help with any of these. This is a select all that apply. Same idea here. If the patient never had to perform the task before by themselves, or has always relied on somebody else to do them, then you're not going to consider those activities. You'll exclude them. You won't code them here. And an example of that is the patient never had to write a check before. So you're not going to code that from the list before because it's not something the patient normally had to do. And then there's information, when we talk about using telephones, it includes dialing and looking up numbers. So ability to find the phone number. preparing own meals, it means including the planning for meals or cooking full meals. Heavy housework for doing housework. Taking their own medication includes preparing and taking the right dose at the right time. Handling own money means writing checks, paying bills, etc. These are just examples. They're not all, it's not inclusive. There's other examples that could be used there as well. The next question is problems indicate if the patient has problems with logical reasoning or memory, cognition. Melinda, would you like to take this one?
Yeah, sure. So we have three choices here. The first one is no, they don't have any problems with memory or cognition or reasoning. And then we have some descriptions of what mild impairment is in the training manual. They may experience frequent forgetfulness. They might forget appointments, social events, where they put things. They might have trouble making decisions or finishing tasks. So this is just mild cognitive impairment. Moderate or severe, we do have some examples in the training manual of that. Memory loss, increased memory loss, confusion, shortened attention span. They may not recognize their family or their close friends. They may have difficulty reading, writing numbers, things of that nature. So I think that, this is do the best you can with this particular question, because I know that sometimes this may be difficult, but we did try to provide some examples to help you to decide which category the patient should fall into.
Thanks, Melinda. That was good. Indicate how the patient rates their own health. Now, this is from the patient perspective, this next question. And it's the patient's own definition of health, if that's social, spiritual, psychological, physical, combination of all of them in an inclusive way. It's the patient's own perspective what their health is and how they rate it themselves. So the intent is to indicate the patient's perception of their own health, and then it's up to the patient to define what health means to them. And the options are excellent, very good, good, fair, or poor. So that question needs to be asked to the patient. How do you rate your own health? And whatever they say, that's how we're going to quote this. And there's a good reason for that. I think usually, or something that I've heard before, is that patients who rate their health better than how the doctor sees them off, I think actually may have a better outlook on life and things like that. So we want to make sure that we get the patient's point here in that question. Next question, we're almost done with questions, and then we can go over to the Q&A. Next question, in a typical week, how often does the patient feel that everything they do is an effort? Everything they do indicate in a typical week how often the patient feels that everything they do is an effort. This intent is to indicate in a typical week how often the patient feels that everything they do is an effort. Effort means to be difficult or trying to do. So the options are never or rarely, not more than once a week, sometimes or occasionally, 1 to 4 days per week, or all the time, 5 to 7 days per week. And that's up to the patient or patient representative to provide that information. And Melinda, you want to take this last one? And then you could do chair rises too if you want.
Okay, so the next one is, in a typical week, how often does the patient engage in moderate or strenuous sports or recreational activities? So when we talk about this, we're talking about activities that will elevate the heart rate, may make the patient sweat. So examples may be golfing or dancing, softball, jogging, swimming, cycling, or similar activities of that nature. This does not include regular paced walking. So we want something that's actually going to get the patient's heart rate up and perhaps make them sweat, depending on the temperature they're doing this in. So And the answers here are never, sometimes occasionally 1 to 4 days a week, or frequently they do it 5 to 7 days a week.
Awesome, thank you. Yeah, do they break a sweat?
Yep. And then we go to the chair rises, and as we said earlier, the chair rises are only for elective cases. Okay, so we are going to be timing how long it takes the patient to perform 5 time chair rises, meaning that they sit in a setting position in a chair, and they have their arms, generally speaking, wrapped across their chest, because they can't use their arms or hands for support to stand up. And then they stand up, and they have to do it 5 times in a row, and you need to time them, whether it's less than 15 seconds that they were able to perform the chair rises for all 5 of them, or was it equal to or greater than 15 seconds, or did the patient attempt it but they could not complete it? So they tried it, but they just couldn't get 5 done. They could only do 3. And then the last selection we have is the chair rise evaluation was not performed, and for whatever reason the chair rise evaluation was not performed. And if the chair rise evaluation was not performed, then we have a child field that opens up so that you could free text in the reason, because we want to see those reasons. It'll help us to understand better. You can type the reason in that the chair rise evaluation is not performed.
Very good, thank you, Melinda. All right, and then I want to show the clinician screening form. It's slightly different than, and there'll be a separate training guide with this to go through it. We tried to include as much as possible. Melinda did our best to keep it on just 2 pages. We tried to add in information right into this form. So you wouldn't have to refer to a separate training form for the person who's assessing this, but if needed, we'll of course make it available. So this is the clinical worksheet, patient name. This will be for site use only, or not, again, clinical worksheet. It's just for your own internal use. The idea is that this will be handed over to the data manager, who will then code in through RedCap. And we'll add in the short names and things like that. We just started working on this one. A couple fields here for site use only. So patient name, date of assessment, and MRN. It's likely that these will be performed prior to the patient going into the vendor software or into IQVIA, especially if you don't have yet a planned date of surgery. And you won't have the record ID or patient ID yet. So for the site, you could just enter in the patient name, MRN, and date of assessment. The frailty assessment, the form must be completed by a clinician and is a judgment-based assessment. You must integrate what you are told, what you observe, and your professional clinical experience. For each question, please check the box that best describes your patient's usual health state. If they are acutely ill, ask about their health state immediately before their acute illness. What the person you are assessing says is important, but should be cross-referenced with family and caretaker. And please ask the patient or patient representative the following questions. The first one, so they're the same questions. Indicate which of the following activities you need any help with from another person. So these are worded as though the clinician would just speak from this form, asking the question here, and then providing the choices. And then we just added in some helper text to exclude activities that the patient has never had to do before, to perform or has always required help with, and select all that apply. Same thing for the next ADL question.
So Carol, the intent of this form, I understand, is for the clinicians to fill this out. Can this also be, I mean, could this be scanned into the medical record too, as the
Yeah, I mean, I think I'm gonna leave that up to the site. For the STS, it needs to be entered into the database. So,
No,
you know,
no, I mean, I don't mean that. I mean, if, because I'm looking at some of the questions coming across, and some people aren't going to
yeah,
have
it's
smart
fine.
phrases. You know,
That's okay.
some people are going to want to use worksheets to get this information. I think it, like you said, it depends on how they want to do it at their site, but
It's
it's
totally up to the site. I mean, if you can get if you can get this form completed on the pre-op evaluation and get it scanned into the chart, and it's a process at your site, and every time you see a new patient that's coming for surgery, this form is being completed and it's being uploaded, and you as the data professional knows where to extract the data from. That's fine, as long as these questions are asked this way and it's coming from this assessment. What we don't want to happen, the idea is we don't want data managers to have to try to, we want this form complete. We don't want data managers to go through the chart and find maybe a cardiac rehab assessment that might have this question on it. Or a neural screen that might have this question on it and pull from different ones. I think we want all of these questions asked at the same time. And I'm gonna lean on Dr. Weiler von Ballmuth to, if he's available, to provide any clarification to that. Because one of our discussions ahead of, in this planning time, and he might have stepped away, and one of our discussions in this planning time is that some of these things are already dictated in the chart, and can we just pull those from that area? And, instead of having double dictation, the answer to that was no, we need this form completed. Exactly how it is laid out here, so we can calculate the clinical frailty score using the types of questions that are used to determine that calculation. So of course you can scan this into your chart as long as it's complete. The idea though is not to go within the other sections of the EHR to try to abstract this material for answering these questions. The form needs to be complete.
yes, it's sort of like the KCCQ for TAVRs. You might be able to find that information in the chart, but you need that KCC in, you need the entire KCC questionnaire completed, you know, so that's kind of the same concept we're talking about here for those of you who do TAVRs.
Thanks, Melinda. So I think it's fine to, as long as this form is complete, was performed at all the questions were asked at the same time from the patient. The understanding is that we're using the training manual for the definitions for what the questions mean. And they're not very difficult questions, but you know, sometimes we can come up with our own understanding of things and make assumptions, or somebody else may make assumptions and chart it differently than what we wanted or intended to capture. So we really want to make sure that this form is complete. As long as it's done that way and you put it into the chart, that's fine if that's your process. I think that that's totally okay. Sound good, Melinda?
Yeah, we got 72. Oh, I was going to say, oh, now we have 73 questions.
Yeah, we could go through there and we could go through them, but essentially this just is a surgeon worksheet. The surgeons can fill it out, or the clinician can fill it out, who's ever doing the screening. And we'll add in the short names, sequence numbers here, so you're able to relate the questions a little bit easier to link them when you do the data abstraction. For the time chair rises, we will add in an instructional video for it to be easier to access right from this form. Cool. All right. Ready for questions? And I just want to, who's ever touching the questions, when you go to touch them, if you hit answer live or type answer, it scrolls it down and then we lose track of the questions. Okay. Can it be done by cardiac rehab? Yes, it can be performed by cardiac rehab.
Yeah, there's a lot of questions about who it can be done by. So a clinician that's been trained to do this. So whether that be the medical assistant that's been trained to do this, or the nurse, or the PA, or the cardiac rehab person, those people
Yeah.
can do this.
And I see like I think if the surgeon or the person who is doing the surgery, it says that they want their MA to perform these before they see the patient, or, you know, part of the preoperative workup. I think that that's totally fine as long as that person is, clinically focused and is instructed on how to do these appropriately. Right, Melinda?
Correct.
If our site chooses to enter TAVRs, is this frailty data required for those cases? I don't know if Dr. Weiler von Balmus is able, to answer this one. I see him.
Which one was that? Sorry if you repeat it for me.
Sure, so, if our site chooses to enter TAVRs, so TAVRs are not required in the STS database since they go into the TBT database. What the site is the frailty data required for TAVRs if they choose to enter them in the adult cardiac database?
Well, we want it for open. We want it for adult cardiac surgical cases, and those who enter TAVRs into the database, I would submit to adopt that also for their valve clinic. That's what we have done. We just use this plus what's needed for TBT in our valve clinic, and so we essentially made the process uniform. So it's required for all adult cardiac surgical cases. The TAVR cases are a special bunch for those of you who do enter TAVR cases in the STS database. I would suggest you make it not unnecessarily more complicated by having different pathways, but it's definitely required for adult cardiac surgical cases.
Okay, thank you.
And Carol, did I looked at the comments a bit, and I think a lot of questions are around surgeon education, and I'd certainly be happy to comment on that a bit. And then around implementation of this in Epic, I saw a few questions, and I can comment on that as well. And then I have a more general sort of comment perhaps around this, and addressing maybe some of the concerns of why these questions are asked, and the whole idea of asking for new or different information. So if you want, I can sort of comment on these topics in more general, or if you want to go through the individual questions, that would be certainly fine by me as well.
It's okay. Well, let me just take this anonymous attendee question, because that might clear up a couple of things, and then I'll hand it over to you if that's okay.
That sounds good.
Okay. So somebody states this does not give us any time to train and implement by April 1st, especially if we don't get the final BCF till next week. Should we really start April 1st? So April 1st is the soft start date. Some of the sites already have processes in place to collect frailty information and are already doing so. So this isn't a big lift for them. Other sites are going to need more time to get going with it. So that's why we have a soft start date for OR surgery dates of April 1st. The mandatory date is January 1st. So we expect that 8 months will give sites plenty of time to train and implement this. So you really have until January 1st, but we suggest you get started sooner than later. And we'd like that data sooner than later. So we can start looking at that in more detail to better understand how frailty and the spectrum of frailty impacts the outcomes for cardiac surgery. So the sooner the better, but we don't expect sites to be up and running April 1st. That's why we have that nice little cushion of a window. So I hope that helps. Okay, go ahead, Dr. Weiler von Balmus, and I'll scroll through these questions to see what we can.
Okay, let me see if I can sort of pull it together. There's questions on surgeon education. There's questions on Epic and how to use this in Epic and what will be made available. The third question I saw sort of as a recurring theme is what happens if the information is not reported, or the forms are incomplete, or information is incomplete that's being provided. So surgeon education, there will be a memo that's going out to the surgeons. We had a session at STS informing membership, surgeons specifically, about this, about our efforts to collect frailty information, the rationale for it, how we arrived at this, how it's validated. and what's going to happen with this moving forward. There will also be an editorial in Annals that will disseminate the rationale, what we have been doing, what we are collecting now, and how we're going to be using that information. So that's perhaps on the surgeon education. We're also looking at doing webinars potentially down the road to help surgeons to get a better understanding, be more familiar with frailty as a concept, and all that goes into this. The second point is about use in Epic. I had shown on previous webinars the use of Epic to facilitate the sort of operational aspect of that. I'm not an Epic super user or whatever those folks are called that are extremely savvy with Epic. I literally highlighted the form and copied and pasted into Epic and made a smart phrase out of it. Epic is actually good enough at this point to turn all the little boxes that are sitting there into interactive check boxes. I'd be happy to record that process for everyone out there to follow through the process of how to do that, and then use a smart phrase that many of you have alluded to make this a simple implementation in Epic. I'm used to Epic. We have Epic, so I'm sure there's similar processes that would allow to do the same in Cerner or some of the other EHR systems, but certainly happy to provide just a very easy editorial, very easy instructional video for how to do that in Epic. The third point was about what happens if data is not reported or incomplete, and what if we just don't collect any information and then January 1st comes around. Well, we're collecting the information because we currently have a huge gap in the performance of our risk models in our performance metrics, because we do not assess level of fitness and vulnerability. That is the whole reason we're doing this. And without collecting information on level of physical fitness and vulnerability, we won't be able to close that performance gap in our risk models and risk-adjusted performance metrics, the benchmarking. So essentially, what will happen for sites that do not report the frailty information, they will stay on the benchmarking and the risk-adjusted performance metrics as they are currently being reported back in the feedback reports. And those who do provide the information will have the benefit of getting frailty, vulnerability, and level of fitness adjusted benchmarking. So look at it however you want. Essentially, what I'm telling you is that sites that will not have this information, we won't be able to provide with better performing risk models and risk-adjusted performance metrics. There's also a lot of questions, I think, in the chat about, why these questions, and some of these questions may be odd. We didn't come up with those. Those are all validated. They have been validated in many studies. There's a reason why they are phrased the way they are, and there's a reason why the answers are the way they are. They all tie in with, again, an assessment of vulnerability and level of fitness on a continuous scale. I've heard a lot of people expressing concern that we're essentially asking sites to do extra work and ask for extra information. And I would submit to everybody on the call here that it is really we're only reframing what clinicians should do when they see their patients. None of these questions are necessarily that different from what a good history and physical exam should look like. In other ways, perhaps think about diabetes. Yes, you could ask a patient, do you have diabetes or not? But if you ask that simple question, you wouldn't really be able to complete the online risk calculator, and you wouldn't have the information about diabetes that we need, whether it's an insulin-dependent diabetes or a non-insulin dependent diabetes, whether it's controlled with medication or just diet. So what I'm telling you here is that this assessment of vulnerability and fitness is really what anyone who's doing a history and physical on a patient that is potentially scheduled for surgery should be asking about: their functional status, their ADLs, IADLs, their level of function. And it's just a specific format that we ask to be reported this back. But it's not really anything new or different that is not typically part of what someone should do when they see a patient and assessing them in their functional status and their level of functioning prior to surgery. And with that, Carol, I'll give it back to you.
Okay, that was a lot of information and very helpful, Dr. Weiler von Baumhus. Thank you so much. That covered quite a few of the questions in here, so I probably won't go through and read each one of these. But there are also some other questions, some other things going on. So one was the date the specs were going, the specs were going to the vendors and how that's going to work. The vendors will receive the specs, we're hoping for next week, that we'll send those out to the vendors. If you want to enter your data before, again, vendors are not required to build this. Some of them have the capability to add in these extra fields on like a supplemental type of form that's not collected to the data version. So they would be able to export over the participant ID, record ID, patient ID, date of surgery from what you enter in the version 4.20, and then fill a separate form and send it over to us on a regular basis before the harvest closes. If the vendors are not able, if some of the vendors are not able to do that, that's, it's okay. We're not requiring, again, STS is not requiring this. We'll send the specs to the vendors next week. And then if the vendors are able to implement this, they will do so. And, every vendor is different on what they're able to do and how quickly. So it's all very different. You need to talk to your vendor specifically about that.
Carol,
Yeah.
this is Paul. Can I jump in just to repeat something that we said on one of the previous webinars? Is just to point out that some vendors that can't do it, it really is no fault of the vendor. So please don't blame the vendors. They had no idea that we were going to do this when they were setting up their software. And sometimes it's a matter of like data security. There's one vendor in particular that I know does not have access to your data. And that's the security model that they set up. And since the vendor has to do the harvest of this data themselves, they're not able to do this. So some vendors can't do it just because of technical reasons that they weren't aware of when they were setting up their software. So, don't blame your vendor if they can't do it. But that's what the Red Cap form is for. So,
Thanks, Paul.
Mm-hmm.
All right, Dr. Weiler von Baumhus, will we have the calculation for the calculated frailty score that we can add in or provide to the vendors so that either the sites can calculate it themselves, or we can provide it to the vendors who are able to offer this to their participants?
Yes, that
Okay.
we can make available. Yes, absolutely.
Okay. Thank you. And then, because I think they use that also for coding into TBT. Still really need simple, concise training for surgeons, PAs, etc. Surgeons, and sorry, I keep on stopping reading. When somebody clicks on the question box, or any questions come in, it scrolls me all the way down. Surgeons have heard nothing about this yet, so they have heard about this back at the annual meeting. I'm not sure if they attended the session, but certainly hear you. We will be sending out notification, next week, like I, stated. We won't see them even discuss this and make decisions on what to do and how to do this until they have that presented to them and can discuss. Yeah, of course. That's why, Becky, we put in the 8 months. We know that it takes a lot of time. This is a big change. Process change for sites take a lot of time, so we certainly respect that and hope that by January 1st, we'll have everybody up and running as it will become mandatory. The Q1 2024 date, the harvest close date, I think is May 24th, Heather. Okay, the frailty assessment will not be in the IQVIA direct data entry form. No, IQVIA is not building this into the direct data entry form. You will need to utilize RECCAP for direct data entry users. Just to confirm, this is only for elective cardiac surgeries, not urgent, emergent, as previously stated. No, Elizabeth, this is for all cardiac surgeries. The questionnaire section is for all cardiac surgeries. The chair rises is for elective cases only. When is STS planning to send this back? So hopefully, next week. The letter is not formulated yet. We'll work on that. Is the date of the frailty assessment form. So good question. I don't see the date and we'll add it in, Melinda, and I will add the date the assessment was complete. The previous webinar stated it was to be done within 2 weeks of surgery. Why did it change? So we had discussions as patients, specifically elective patients, are seen, often can be seen greater than 2 weeks prior to surgery. We didn't want to have the form need to be repeated or anything like that. If they see the patient, usually we say 3 months is a good time frame. If they see the patients within the 3 months before surgery and have completed the form, patients elective, nothing major changed, then you can use that form. If the patient status did change significantly, then we would ask for another form to be completed. This will be laid out in the training manual for you. Asking frailty questions to post-op. This is regarding asking frailty questions post-op for urgent emergent patients. Will this be required or just suggested? No, it will be required. The only part that will be removed from not being required are the chair rises. We do not want you to have to perform chair rises on those patients. The form I am presenting is not posted yet. It'll be posted by the end of next week. Just to clarify, if the changes to patient status, we have to submit another frailty. Yes, so the patient will have 2 frailties submitted. So not submit another frailty, you'll need to complete another frailty and only submit 1 to STS. It needs to be the most recent for the patient's baseline status prior to going into surgery, excluding any acute events that may have happened to that patient. So it will be in the training manual, Angela, and we'll go through it in more detail if needed.
Well, it's sort of like doing the risk assessment. You know, we have that same language basically in the risk assessment field sequence 1966. If something changes significantly, then you need to do another one. And it's my understanding from Nikki, and she's not on the phone call, but Carol, if they submit the REDCap form and then there is changes and they have to submit another one, then the original REDCap form will just be replaced by the newly submitted one, correct?
Yeah, that's correct, Melinda. Thank you for bringing that up. So if the REDCap form has the same patient and record ID on it, it will replace the one that has already been submitted. That's right.
And while I'm talking, can I ask a question? Because I see there's some questions here about heart transplants, bad cases, TAVRs, and I'm bringing this up while we're here on the call because we have two different types of patients that are put in the database. We have the required entry database patients, and then we have all of these optional cases. So just from my understanding, Dr. Wallace, should we be completing this assessment on just the required entry cases, or should we be including this on the optional cases too, which can be like standalone ECMO, standalone VADs, TAVRs, things of that nature that some sites put in and some don't put in?
For the time being, this would be for required cases.
Required cases.
Yes.
Okay.
Thank you, Melanie.
Thank you.
Okay. RedCap is I'm new to RedCap. What's RedCap? RedCap is a data collection platform that's HIPAA compliant that we utilize to capture secondary data. We're using it for the beta blocker project that we're collecting on isolated cabbage cases. We use it for the additional valve types for valve procedures that aren't available in the data collection form. So you can find more information. We have a link to the RedCap site within, I believe it's within the training manual that's posted now, maybe under the beta blocker project. When you say required cases, do you mean analyzed cases? So there's a difference there between required and analyzed cases. Not all required cases are analyzed, but all analyzed cases are required. So the required cases might include something like an aorta case, which currently isn't analyzed. We don't have a risk model or a PROC ID for it right now. So that's still a required case. So there is a required case document posted on the STS website that you can refer to. And I'll show you where that's at.
Yeah, the case inclusion document has the required entry cases and it has the optional entry cases.
If a patient has a long length of stay and is urgent or emergent, are providers expected to do this questionnaire weeks after surgery? What if the patient dies? And I'm assuming the patient dies in the meantime. Dr. Weiler,
That's really two questions, isn't it? So
yeah.
we have two questions. What happens if the patient dies and it's not done? And what happens and how? We said in the training manual it can be done anytime post-discharge, prior to discharge. But the patient has to answer the questions based on their baseline status prior to this acute illness or hospitalization.
Well, and I think that we also said family members or caretakers could answer the question, right?
Correct.
So,
if the patient's unable to do it.
Yeah, if the patient's not able to do it, but we also said that we could have, right, what did Dr. Weiler von Baumann say here? Hold on.
Yeah, so essentially, if someone comes in as an emergency, as intubated, obviously isn't able to answer these questions, the beauty of using this frailty assessment is that it can be obtained with the help of family members or caretakers. Now, the longer one would wait to obtain that information, the harder it will get to obtain that information. So I would say that if, to not make it unnecessarily more cumbersome to collect this information in these emergency cases where the patient is not able to provide the information, to obtain that information at a time where family member or caretakers are around, because later on one would have to go out and find that information, which obviously makes it much more difficult to obtain that information.
Thank you. Could you talk about patients who use walkers? Is that considered help? So a patient needs help with walking. So on the ADL question, we're talking about which of the following activities the patient needs any help with from another person. Should we also think about supportive devices here?
Yes, that would include supportive devices.
Okay, so we'll add that into the training manual. I hope, Melinda, are you able to take notes?
Yeah, I'm taking notes.
Okay. See, this is why we don't post anything final until after we have a call with you. All right, so adult cardiac surgery database, to get here, I went to research and data for data managers and adult cardiac surgery database, access data collection resources, version 4.20, and then we have this very nice form that says case line care that says case inclusion guide. If you click on that, it's going to come up with a list of the required and not required cases. So the first list is the required cases. These are in conjunction with other CV surgeries or standalone procedures. These are our analyzed and non-analyzed required cases, cabbage valve, aorta, and then the other types of repairs like LV repairs, LV aneurysm repairs, cardiac tumors, minimally invasive PFO closure, etc. All of these are required. AFib cases are required. ICD pacemaker lead extraction, VADs in conjunction with CV surgery, concomitant procedures with required procedures. And then the optional cases are things like ECMO or Impellas. Now, these are standalone ECMO and Impellas. Patient didn't have anything else during their hospital stay. They only had a ECMO place. This case does not have to go into the database. It's optional. Same thing with the VAD, if it's not done in conjunction with an analyzed or required procedure. Well, we don't collect standalone durable VADs or temporary VADs in the adult cardiac database. You can enter them in, but they are not required. Same thing with total artificial hearts, TAVRs, TMVRs, angiovacs, and hearts, lungs, transplants, the elbow and the UNOS, unless you want to enter them into the ACSD as well, you can do that, but not required. So that's the list. All right, we got that question answered about ABLs and once frailty, Emmanuel's asking, he's from one of our vendors, once frailty collection becomes mandatory, will that be still through REDCap, or would it become part of the official adult cardiac data set? So frailty data collection is not going anywhere. We're going to make that a permanent part of the ACS adult cardiac database. However, we do not have an upgrade planned at this time. When we do have an upgrade, our next upgrade for adult cardiac, which is not planned at this time, I have no insight into that. I don't have even a guess at when that's going to happen. The frailty will become part of that upgrade. So we don't have anything right now. Okay. I hope that answers your question. And the question about through REDCap, how would that be enforced? So we would be able to link the data collection with the version 4.20 data in the Research and Analytics Center here at STS to see completeness rates for the frailty question. How are we supposed to know if they've needed help prior to this? With all due respect, what difference does it make if someone needs help with writing checks? I'm so confused by some of this. So these are indications of frailty. And this is Dr. Weiler von Baumers. I'll let you take this one if you have a few additional minutes. I know we're over time. Melinda,
Yeah,
are you able?
happy to address that. So
Okay.
while it may seem odd, again, these were not picked by random. These are instrumental ADLs and are an established metric of vulnerability. So along with the other questions there, being able or not able to do activities of daily living and the instrumental activities of daily living provide a metric of fitness and vulnerability in our patients.
Well, can I ask a question to you then? So, because I think this is what they're really getting at. So why would we exclude activities they've never been able to do? Would that not indicate that the patient is frail? I think that's the real question here, is why we exclude those activities.
Yeah, that's a good question. We're not excluding activities someone has never been able to do. We're excluding activities that patients have never attempted at doing or been doing. So an example, if someone is married and their spouse has always been doing the finances, That's not a reflection of them being able or not able to write a check and do the finances. It's a reflection of the arrangement that they have. That's different from someone who has been writing checks and now is not able to write checks anymore, if that makes sense.
Yeah, and I think I screwed that up. I think that we talked about this and it's not how I interpreted what was said. So the one I used was walking around, because in the training manual we have, if the patient was never able to walk around, don't count that as a frailty, and it does not make sense. It should be, if the patient was never able to walk around without a walker or without assistance, we should be looking at that as being frail, right?
Is that question for me, Carol?
Yes, yes,
Yes.
sir. Thank you. So we'll have to fix that in the training manual, Melinda. See, this is why nothing is final until we talk to you guys.
Well, I was always confused on that myself, so I'm glad that it's clarified. So this is a person that's never, and I guess I'm most confused with the ADLs. So if somebody was born and they couldn't walk, would that be,
So to make it very simple, it's the change in status that we're looking
a
for.
change in status?
Yeah.
Okay. So
If
they once could
someone-
walk.
If
they could-
someone for 15 years was able to do their finances or walk around, but for the last 10, they haven't been able to do that anymore, that it's the change in status.
Okay.
But what about that patient that has never, and I'm sorry to belabor this, but what about the patient that maybe through some type of genetic deformity or something tragic that's happened to them during birth, they were never able to walk around, right? They were never ambulatory.
You know, as everything in life you're trying to assess and measure, you have to strike a balance between being practical and being effective. So, and we can certainly, you know, look at the training manual to make sure there's clarity for this in the training manual. There's undoubtedly examples anyone could come up with where this is not possible, or find that one of a case where where something wouldn't add up. No question, always possible. I see a lot of questions about all these emergent cases that die in the OR. Well, all these emergent cases that die in the OR are a mortality that will, you know, count towards your mortality already. So again, you know, I know there's a lot of one-offs that and very unique circumstances where something might be difficult to obtain or assess, or even with these questions, the way they are phrased, or these answers, it might be difficult to answer it. But this has been used across the NHS in the UK, so it's been rolled out with these questions, with this verbiage, the way the questions are asked, the way the answers are provided across an entire healthcare system in the UK. It's rolled out across the entire healthcare system in Canada. So others have done that before us, and with great success.
Thank you. There are so many questions. We can't get caught up. I feel like I'm stuck in my email box. I can't get caught up. So Amy, it's a good question. Amy's saying that she's wondering if it's easier just to collect the frailty score, and there's a reason why. Did you just answer that, Dr. Weiler Van Bommel? There's a reason why we're not collecting just the score, and we're asking the questions that go into the score. The reason is that we need to get the more granular information to calculate the scores ourselves, because
yeah, it's
often,
essentially just asking for a number is much like asking for the eyeball test. And again, it goes back to the example, and I don't know if it resonated at all or not, what I said. Most surgeons will walk into the room and say, so Mr. Smith, what are you able to do? Are you able to get around? Do you need, you know, do you use a walker to get around? So all these things are asked. It's just a specific way of asking it and making sure we're documenting it in a specific way. And again, the example I gave was with diabetes, or one could just ask, are you a diabetic or not? But we're now and have been collecting more granular information on diabetes. The risk with just asking for a clinical frailty score is essentially the same as asking, do you think the patient is frail or not? And wouldn't really be helpful, and ultimately not allow us, again, to close that performance gap that we have in our risk models and risk-adjusted performance metrics.
Thank you. All right, just to clarify, so let me clarify this a little bit better. Just like Alan, your question about completion thresholds for all required cases, just not analyzed cases. So the required cases are required to be entered in, just like your participation agreement with STS says that you're going to enter in all of the data fields for the required cases, not just analyzed cases. These are part of those required fields. So these are going to be required. These variables will be required for all of your cases, all of the required cases entered into the STS database. So the thresholds, however, just like for the thresholds for analyzed cases, the thresholds are applied to the analyzed cases that we have risk models on. So wherever this frailty information is used for risk adjustment, there will be requirements placed upon, threshold requirements placed upon those procedure types. Now, we don't know where it's going to be used or how it's going to be used right now because we don't even have any data yet. So usually it takes about a year to get enough data to start looking at it, to include it in, consider including it in any type of risk models. And those models take quite a while to be built. So we still need to get the data in yet before we can talk about where the data is going to be used, how it's going to be used, and the thresholds and what those thresholds will look for sites. So there will be more to come, and of course, we'll keep you all updated as we go through this together on those types of details.
Carol, maybe just as agree with everything you said. One thing I can speak to just briefly is implementing this in the risk calculator and the risk models and the performance metrics. One thing we're really proud of is the move from DCRI to in-house research and analytics, and with that being much more nimble and flexible in adding new components to our online risk calculator, as well as our risk models and the way they work in the background, the feedback reports. As all of you will see that in the coming month, I think the month of April will be an exciting one in terms of updates to the online risk calculator. And the same again goes with this frailty information, that now we have a pathway and a mechanism to implement new information like this frailty information quicker.
Now, thank you. Now, there are questions in here, and I think they're really great questions because, sometimes we get pretty grumpy patients. What if the patient refuses to answer any of these questions? And there's no family member around. You get the patient who's really, really grumpy. Have you ever had
I don't know what people do and how they write an H&P, because yes, patients may
totally
be grumpy, but we still have to find out if they have, again, diabetes or high blood pressure. That's a reality.
Yeah. And then I see some
of the grumpy patients are the best ones at the end of the day.
That's right. You got to do your best to get the information on the patients. I see some pretty off the chart questions here about if the patient comes to the OR, there's no family, and then the patient dies in the OR. The expectation is that they would call the family to get the frailty assessment on the patient. And I think that was totally misunderstood in what was said. I'm not certain that was said here on this call, but would you like to address those types of patients? Because I'm sure that will happen.
Yeah, I think one way of looking at this is that, again, if the patient dies, you're going to have a mortality, and it will count as a mortality. Now, on the flip side of that, if you have a patient and the patient survives the emergent procedure, and you not only do your STS, but you also document your frailty, you will look way, way better than if you didn't do it. For those few patients that are emergent and die on the table and no family member is around and all hell is unleashed, that yes, can certainly happen. But unfortunately nothing will really help you because you'll have a mortality and it will count towards your benchmarking as a mortality.
What do you suggest they do in those cases regarding?
We can provide some guidance for that in the training manual.
Okay, all right, very good, thank you. The 5-meter walk test is not being removed. We're still encouraged sites, if you're collecting it, to please still collect it.
And also, Carol, I keep recurring questions here on the data collection form. And again, the clinician's version looks different and has more instructions around these instrumental and activity of daily living. It has more instructions about the chair rise exercise. So this, what we're all looking at here is the data collection form from a data manager's perspective. The one we'll be providing for clinicians to use has more instruction around it. The reason we took it out from the data collection form here for the data managers is because we don't expect you, the data managers, to go through the EHR and try to compile this information. We're providing this, and we could have made it even simpler to make it easy to match it to what needs to be documented by the clinicians. And again, the clinician version of the form we make available will have additional information with how to administer those questions, how to ask the questions, and what is meant, for example, with people that have not been doing something, what it means if they've never been doing it versus they have changed and are no longer able to do an activity.
Thank you. And I know we've said this before, but Donna, I'm not familiar with your name, so maybe you haven't been on our other webinars. The timeline that this is completed, so elective pre-op before the patient goes to surgery, preferably within, the 90 days leading up to surgery, unless the patient's status, physical function or frailty level changes drastically, then you'll want to repeat the frailty assessment to be the patient's baseline going into the operating room. And then for urgent or emergent cases, you can do it prior to surgery, or you could also do it after surgery. The chair rises are only for elective cases only, so we don't want these standing up patients that are very, very sick and having them sit up and down 5 times real fast. That probably wouldn't be a good idea. So we're doing this just for the chair raises for elective cases only. Yeah, they would really like a video on the smart braces or something to help them with the smart braces.
And I'm happy to make a video.
Thank you. Yeah. All right, I don't know what you want to do here. We still have 85 questions. We're way over time. All of this defense of doing this work needs to be given to the surgeons. We are not in a position to repeat this to the surgeons. So Beth, as we had said, information will be sent out. We'll make this all available. We'll have a training guide for the surgeons. So hope that helps. We want to make you as successful as possible, but there has to be some help from your side too, just similar to when we start collecting other data points or when we started collecting, more information on the aorta. We have to try to help our surgeons give us the information that we need to abstract it, because it's going to help them. So, you know, busy surgeons who are in the OR for 8 hours, 10, 12 hours a day, every day, they don't have time to read their emails or to sit through training sessions. So we really depend on you to help with this, especially since it's related to the outcomes that, you know, that will be eventually, it will be part of. We want to make sure we're able to get everybody on board. Hopefully 8 months is enough time. So, Vicki, and so I hope you understand, we're not trying to push this on the data managers. We're educating you because your surgeons are going to be coming to you first, of course, right? So they're not going to be reaching out to STS with questions. They'll be reaching out to you because they know who you are. So you are our advocate, I guess. We're all working together on this, so we're all part of it. And it's for the patients. You know, we have to realize that frailty is a big part of the predicting of patients' outcomes, and specifically bad outcomes after surgery. And with missing this information, we're missing out on really understanding how frail patients are doing after surgery. We need to better understand these patients so we can maybe even do prehab with patients and get them as unfrail as possible before surgery, or precautions, or set them up with social services to get them, you know, things in place at their home. So when they go home from surgery, they're not likely to have a fall on slippery rugs or something like that. So that's what all of this is about. And it's about the patient. So even though it sucks that we have to go and ask you to go to your surgeons and teach them how to do this, it's really, at the end of the day, it's about making sure our patients are living better, longer lives after they go through this massive surgery, you know, through these surgeries. So I know it's painful doing those new things, but we'll help you as much as we can, and whatever information we can provide, we will provide. So I'm going to end the call here because we have you know, we're way over time. We're a half hour over time. I know we have a lot of other questions to go through. I apologize, we can't get to all of them. We will review these. Melinda and I will review these. I'll review them. I know Melinda's really busy, but I'll review them, pass things along to Dr. Weiler von Balmus and to Melinda to make sure we can add these in. And then see what else we need to help you. Try to get the data collection form, or we will get the data collection form and training manual and clinical worksheet posted by the end of next week. And once we get those posted, then we'll send out the email to you all, which you can share with your surgeons. Typically don't send out these emails to surgeons because we have found, you know, we're, like I said, many of them who are at busy practices don't always have time to check their emails. They're going to miss something, or they're not going to understand it. And we have been able to share this information in detail with you all. So we rely on you to pass it along to your surgeons if you want to get their support in collecting this. You know, the other thing, you can work with the office staff. If your surgeons have office staff, you can work with them. Usually if you explain it to their team, they're very helpful in implementing these things for the surgeons, and often they have really good relationships with those people. They work with them closely, so they'll be a good support person for you. And then also you can work with your pre-admission testing staff at the hospital, let them know, hey, you know, we need to start collecting this information. Other people might have really great ideas on how to get it done. So I know this is a lot, but we'll all get through it together. We've got lots of time to get everybody on board. So all right. Well, thanks, Dr. Weiler von Balmus. Thank you, Melinda. Thanks, Banu. Thanks, Leanne. Anybody else have anything left? Last minute messages?
Well, I just want to say thank you so much, Carol, your team, everyone, for putting this together. Thank you for all of you on the call for supporting this very important initiative. And I know it's a change, and it's extra work, ultimately, yes, but extra work really in the interest of helping our patients better. Thank you.
Thank you very much. Thanks, everybody. Have a great rest of the day. Thank you, Melinda.